fetal tissue that remains in uterus after a spontaneous pregnancy loss, planned pregnancy termination, or preterm or term delivery. So the incidence varies according to the gestational age. After term pregnancy, it is 1%, and after abortion, it is 0.4 to 6%, and it is most common after second trimester abortions. And after manual vacuum aspiration and medical management, it is incidence is a little more. It is 13% and 29.4% respectively. WHO estimates 56 million abortions take place globally every year, and unsafe abortions attributed to 4.7% to 13.2% of maternal deaths, and many of these unsafe abortions present with RPOC and its complications. So what are the risk factors for RPOC? So history of previous RPOC is an important risk factor, and also uterine atony, preterm labor and miscarriage in the second trimester, placenta accreta syndrome, uterine anomalies, previous uterine surgery, placental abnormalities. So what are the complications? Short-term consequences of RPOC include hemorrhage and infection, and whereas long-term consequences include formation of intrauterine adhesions, which is called Asherman syndrome, and the consequences like structural bleeding. The diagnosis of management of RPOC are challenging because there are no clearly defined diagnostic criteria, no defined treatment protocols. A diagnosis depends mainly on the clinical presentation, the history, examination, ultrasonography with the color Doppler, hysteroscopy, and HCG is not much helpful. It is done usually to exclude gestational trophoblastic disease. And the histological diagnosis is based on the presence of chorionic buildup. Clinical presentation of RPOC includes commonly it is presented as abnormal uterine bleeding, mostly postpartum, secondary postpartum hemorrhage, pelvic pain, amenorrhea, pyrexia, and offensive vaginal discharge. The diagnosis is mainly dependent on ultrasound. A combined grayscale and color Doppler ultrasound is the first line modality, and it is the gold standard for the diagnosis of RPOC. And it allows real-time assessment of uterine structures and blood flow. And magnetic resonance imaging can be helpful in some complicated cases. And the diagnosis is made in the presence of in the grayscale ultrasound, a heterogeneous intracavitary hyperechoic focal mass with poorly defined endometrium myometrium interface and increased anisotropy about 20%. So it is mainly useful in the exclusion of RPOC. So negative predictive value for RPOC is 63 to 83%. So the degree of vascularity in a thickened EEC, that is endometrial echo complex, can help to improve the diagnostic assessment of RPOC. So demonstrating blood flow in the mass can help distinguish between RPOC and a hematoma, as well as to classify RPOC on the basis of its vascularity. So highly vascular RPOC can be sometimes confused with arteriovenous malformation, a rare case of postpartum vaginal bleeding. So if there is a vascular component seen in RPOC, it will be located in the endometrium, whereas in case of arteriovenous malformation, the vascular component is seen mainly in the myometrium. So it is important to distinguish, because if you attempt a DNC in AVM, there will be torrential bleeding. So besides arteriovenous malformation, another potential mimics of RPOC are underlying endometrial abnormalities such as an endometrial polyp, a submucous fibroid, a subinvolution of the placental implantation site. So there is a classification that is based on the ultrasound patterns of RPOC and echogenicity. So type 0, that is hyperechogenic avascular mass, which may be a vascular arteriostomy or it may be a blood clot. So this usually expelled by itself without any much bleeding. So it is less risk. There is less risk in this case. And type 1 also different echoes with minimal or no vascularity. In this case also the bleeding will be less. And type 2 and type 3. Type 2 is highly vascular mass confined to the cavity, and type 3 is highly vascularized mass with a highly vascularized myometrium. So in these cases, the bleeding will be, if you attempt a DNC, the bleeding will be more. So here we can better to go for hysteroscopic removal of RPOC using an energy source to prevent bleeding. So the use of Glutenberg classification for RPOC is not only crucial for surgical planning, but is also important for patient counseling regarding the management options. So hysteroscopic diagnosis of RPOC depends on the appearance, like polypoid lesion with a smooth surface or friable micropapillary texture, overall hypertrophic appearance, well-defined boundaries, friable necrotic foci that bleed easily. So this is a hysteroscopic picture of RPOC. This is Glutenberg classification. In type 0, there is a white mass with no clear structures, and type 1 well-defined avascular chorionic villi, and type 3 well-vascularized chorionic villi, and type 4 aneurysm over the myometrium in the implantation site. So management of RPOC. The main aims of the management are to stop bleeding, to prevent infection, to avoid long-term complications, and management is based on severity of the bleeding, the presence of intra-uterine infection, the ultrasound characteristics of the retained material. So expected management and medical management, this is vitrotonic, where we use vitrotonic medications such as misoprostol. And methotrexate is also can be used, which reduces the vascularization and resorption of the retained placental tissue. And surgical intervention such as dilatation and curettage, vacuum aspiration, and hysteroscopic removal, and interventional radiology, that is uterine artery embolization, is used in cases of life-threatening bleeding. And complete evacuation of the retained products when treated with expected management is between 47% to 81%, whereas with surgical treatment it is 95 to 97%. And the conservative management, endometrial thickness less than 10 millimeters, there is no blood flow or enhanced myometrial vascularity and ultrasonography, and when there are mild symptoms. So these patients can be managed conservatively with 93% specificity and 90% positive predictive value. And you can start antibiotics like amoxicillin and clavulanic acid for 5 days. Observation of temperature, pulse rate, full blood counts, and follow-up is needed for 2 weeks. And dilatation and curettage. Historically, DNC has been the first choice, even though it is a blind procedure. Because it is a blind procedure, there is a risk of incomplete removal, exposing the uterus to unnecessary trauma, like risks of bleeding, risks of uterine perforation, and potentially damage the basal layer of endometrium, which leads to intrauterine adhesion formation, which lead to subfertility. And DNC is reported to be associated with an up to 30% chance of generating intrauterine adhesion formation when compared to hysteroscopic removal, which there is risk of only 4 to 10%. The risk increases with repeated curetages. Abnormal embryonic implantation in future gestations predisposed to abnormal placental development, fabric placenta accreta with its potentially dangerous consequences. To improve safety and accuracy during the procedure, DNC can be performed under ultrasound guidance. Hysteroscopic removal of RPOC. This is a safe, effective and minimally invasive procedure which enables to remove the RPOC in a precise and targeted fashion under direct vision. So it decreases the damage to endometrium and preserve the integrity of the uterine cavity, minimizing the rates of intrauterine adhesions. And it decreases the fertility problems also. And direct visualization lead to complete removal of RPOC without the need for a second procedure, and identification and treatment of uterine cavity anomalies, which are sometimes the underlying cause of RPOC, and can be done with a receptoscope using a cold loop or a hysteroscopic modulator. The Gutenberg classification can be very useful in surgical planning as it predicts the risk of bleeding during hysteroscopic removal of RPOC, allowing to determine the setting of hysteroscopic procedure and whether to use energy source. The reported success rate is around 95 to 100%, and persistence of RPOC is seen in only 1.4% of cases compared to 28% of cases which are treated with DNC. So, take-home messages to the written products is a common problem with complications of associated with spontaneous miscarriage, and Doppler sonography combined with grayscale ultrasound can improve the accuracy of diagnosis of written products. Vascular grading of RPOs and ultrasound and color Doppler aids in proper triage of the patients. And operative hysteroscopy should be considered the treatment of choice in women with RPOC as it is safe and feasible procedure with low rates of post-operative intrauterine adhesions. I invite you for the next coming APCOG, which is held in Kakinada. Please make it successful. Thank you.